alaikum. Good morning, everybody. Thanks for the GIS leadership tapping into this important topic for our region. And in behalf of a very active working group, I'm presenting the work, specifically in behalf of Dr. Ahmed Al-Shatti, and multiple panelists from different countries reflecting our GCC area, moderated by Dr. Ahmed Al-Shatti from Kuwait. I think one of the important aspects of our day-to-day practice within TAVI in the region is there is identified gap of knowledge. TAVI has gained its position for high and for low risk patient, guided by the randomized trial that included specific inclusion criteria. However, if you look back at your daily practice, there are patients that clearly fall outside those indications. Examples are including bicuspid aortic valve, patient with an uncalcified aortic stenosis, or what's so-called fibrocalcific, which is also abundant in our region based on individual experience. Patient with pure aortic insufficiency. These are areas that actually, unfortunately, we do not know the incidence within our GCC area, but there are some relevant prevalence studies all coming from the West. In addition to areas of structural valve deterioration. Each of those areas are considered a special population. The document is basically a glimpse of a great work led by the GIS. And as Dr. Fawaz mentioned in his opening speech, it is very important for us within each center and each country to reach out to help ourselves and our future generation in defining the prevalence and the disease process for those special population. The methodology is similar to any consensus documents, with the panelists reviewing the literature in relation to specific or special population, including severe aortic insufficiency, fibrocalcific AS, and there are more to come in relation to cardiogenic shock and chronic kidney disease, all of which are important for our daily practice. So the first part of the consensus deal with the bicuspid aortic valve. This is an irrelevant area that till this day, I do not know what is the true prevalence of bicuspid aortic valve within our region. Between the far east and the far west, you find variable prevalence up to 20%. Why focus on bicuspid aortic valve? It is definitely a totally different animal than the tricuspid valve, with specific anatomical variability that include significant leaflet calcification, how to address patient with orthopathy, and historically those patients has been excluded from randomized trial. Most of the data we are gathering at this stage are based on registry in relation to bicuspid aortic valve. So these are unique population, and the key recommendation based on the review of the panelists of the current literature relies on a couple of practice points. One is related to imaging and sizing of the bicuspid aortic valve, and there is a clear, strong recommendation based on evidence related to the method of sizing, a combination method that includes the intracommissural dimension, and also specifically for balloon expandable valve using the circle method and the LIRA is actually of strong indication. The second part is, or the second recommendation is related to patient selection. We all face the patient who have bicuspid aortic valve and orthopathy. It's a distinction feature that we need to look for in our selection for patient who does have aortopathy, but the size did not reach intervention and they are of high or intermediate risk. Is TAVI can be considered, but the amount of evidence put it in the moderate range. The third point, which is important for the practitioner, is the selection of the platform. And there is definitely no stronger recommendation here. It's a moderate recommendation, but basically favoring a balloon expandable valve when you do not have heavy calcification to achieve sealing, and favoring a self-expanding valve for patients with large annuli and significant calcification, but bearing in mind the chance for under expansion of those platforms. If patient does have orthopathy with an aorta more than or equal to 45, then the heart team discussion becomes very relevant in relation to whether or not to offer this patient a definitive procedure that address both, or for those patients who does not or cannot be a candidate for surgery, basically looking into the progression of the aortic valve, the aorta disease, and this is detailed in the document. This is definitely a high or strong recommendation. Also, the documents goes into a visual of green versus lead. I'm not going to go over this in details, but also highlight the main theme related to the heart team, the CT planning, the device choice, emphasis within the document itself on the device expansion and the assessment of the aorta. The second part of the document deals with the non-calcific aortic stenosis. There is definitely in this area a clear lack of evidence to guide the practitioner, but this is something we see a lot in our area, and there's a huge emphasis on the CT scan and the role that the CT scan play in the assessment of the calcification, and this all the CT scan assessment, the aortic valve calcification assessment, all carries a strong recommendation with a strong strength based on the current available evidence. The other part of this document in relation to patient with TAVI and non-calcified valve deal with the lack of evidence in relation to the choice of valve, but for the individual dealing with such patient, it is all about whether the device or the platform being used is sufficient for anchoring and provide sealing. And the last part, which comes to as a strong recommendation in relation to the implantation depth within those patients with non-calcified aortic stenosis to achieve proper sealing. The other part is the TAVI with pure aortic insufficiency, and as I alluded to at the beginning of my talk, there is a lack of data related to the prevalence outside rheumatic heart disease in our area. Most of the available platform, especially the second and third generation, can be used, but the consensus clearly emphasize the role of CT scan in planning the procedure. The second thing, there is no specific oversize ratio, and that is why the recommendation comes with moderate, because depending on the platform, it can be between 10 up to 20%, respecting other structure and the risk of causing conduction injury. There is also, in the reviewing the literature, some favoring for a repositionable device that can be more forgiving during the deployment. Again, strong emphasis in the current available surgical treatment for pure aortic insufficiency. Last recommendation based on moderate evidence related to a dedicated system, the Trilogy, for example, which gained acceptance after its recent trial. So overall, this is another area that hopefully we will get more information in the future through collaboration across the GCC. The last part of this document or this presentation is related to valve and valve, and this is definitely an area that we will be involved in more in the future. Most of the recommendation in this section carries a strength that is strong related to the evaluation of patient for a potential valve and valve procedure, and the mandatory CT scan, the mandatory reporting and seeking the information about the initial surgical valve, two sources of information including the operative report and using the valve and valve app. It is also important that the reporting of the CT scan includes some important information like the VTC and the VTC STJ. Treating patient with those valve and valve procedure, it is important that those information also available to the heart team in order to risk stratify the patient and guide the patient to the procedure of least risk. It is also important and highlighted in the document that a strong recommendation is that for externally mounted bioprosthetic valve, the risk also is high for coronary obstruction. It is also part of the pre-procedural planning, and it comes to the heart team and the operator to really define the future access for coronary access and choosing the appropriate platform that can also serve the patient when we come to the concept of the lifetime risk. It is very important because when we discuss patient with valve-in-valve, the consensus give a strong indication to not providing valve-in-valve if the risk is considerably high for coronary obstruction, and this definitely has to come through a heart team discussion. Now, keeping in the same theme of the valve-in-valve and addressing the risk of this procedure, the consensus document gives a strong recommendation for valve-in-valve in patients with bioprosthetic, with a failed bioprosthesis, and those with high or prohibitive risk based on the surgical team assessment. Most of the currently available new generation transcatheter valve has better sealing than the older generation, so it is definitely less likely to run into the scenario of paravalvular leak. Small surgical valve, it comes down also to the pre-procedural assessment to assess for the risk of patient prosthesis mismatch. And due to the lack of consistent data on the outcome of patient with patient prosthesis mismatch, this recommendation strength was moderate. For patient with high risk for occlusion, pre-procedural planning should include mitigation of coronary obstruction for those patients defined as high risk by the VTC and the VTC to STJ. So a leaflet modification or some form of protection. This can be in the form of basilica or a balloon assisted. Again, the data behind those two procedures are developing, and the strength of the recommendation hence is moderate. Avoiding the preemptive chimney technique because of the associated stent deformation and higher risk of late stent occlusion and stenosis, also reflected in the consensus document. I think the important part for this consensus is also to introduce the already known concept of lifetime management in the patient, and this comes in the initial procedure. So I would like to conclude here and thanks the GIS and also encourage all of us really to be part of the future of developing data for the GCC.